Hello everyone, welcome to Pulmonology Read Aloud, the channel about pulmonology, latest updates, and articles read aloud to you. Today I'll be talking about preoperative pulmonary risk evaluation. I thank my subscribers for suggesting this topic, and today we're going to talk about the approach to a patient where you have been called for a clearance or a risk evaluation before surgery. So let's ask ourselves a few questions and try and understand what is the context of evaluating a patient before surgery for a respiratory issue. Now, very commonly, patients undergo surgeries for thoracic or extrathoracic causes, and either they have a predisposing factor which calls for having a pulmonologist see the patient, or the patients may be suffering from an acute episode just prior to surgery, especially in surgeries that are more urgent surgeries. So there is always a risk of post-operative pulmonary complications, especially in patients where the surgeries have to be done urgently for certain causes more than an elective surgery. And post-operative pulmonary complications are a major part of all post-operative complications. These are those complications that affect the respiratory system. So acutely after the surgery, majority of patients in the form of respiratory system involvement will either have some hypoxia because of atelectasis, some patients may have bronchospasm, some patients may have postoperative cough or tracheobronchitis, and less commonly, but then quite severely, some patients may actually have postoperative pneumonias, ARDS, pulmonary embolisms, respiratory failure, repeated intubations, prolonged ICU stay, and more. So, this becomes really, really important preoperatively to assess how this patient will fare after a surgery. In Western literature, almost 2 to 33% is the reported prevalence rate of postoperative complications involving the respiratory tract. So, when we're talking about the post op complications, we must know what is the physiological changes that will happen to the lung during surgeries, which will predispose a patient to these complications. Now, what happens is that if we have any form of surgery, especially surgeries that are prolonged or are major surgeries, there is more release in stress hormone, so there is more catabolism. So, overall, post operatively, the patient is likely to have a negative energy and a deficit leading to loss of respiratory muscle tone. There may also be in patients with general anesthesia an airway collapse, an atelectasis, which leads to hypoxia because of VQ mismatch. Especially patients who are undergoing upper abdominal surgeries, thoracic surgeries, there may be an impaired cuff reflex, there may be an impaired strength, patients may be recumbent in position for a long time, which may further lead to respiratory symptoms and complications. And because a lot of patients have pain after the surgery, whether it's a thoracic or an extrathoracic surgery, there could be a reduction in the vital capacity. So, all efforts post-operatively have to be made to prevent this complication. So, there are always certain patient related complications, certain surgery related complications that may cause the risk factor for that patient. So, when we are evaluating a patient preoperatively, we have to make sure that we're choosing the right patient. And if this patient is deemed to have more risk of complications, then we are prepared beforehand. We have very clear instructions of the post operative period, and the patient also knows the kind of risk that is involved. So usually when you look at any patient, the more advanced the age, especially above 50 years, that is independently a risk factor of having a post-operative pulmonary complication. And this risk is irrespective of his comorbidities. Just being above 50 years will have an increased risk independently. The other factor is cigarette smoking, and it's been seen that smoking increases the odds of postoperative pulmonary complications. So, current smokers have more postoperative complications, and especially if they have a smoking history which is relevant, which is more than 10 pack years. So, smoking cessation forms a very important part of an effort in reducing post op complications. Also, the functional and the general health status of the patient, the Karnofsky score, the functional score, that's important. Whether the patient is very thin built, cachexic, or the patient is good built, whether the patient is able to do his daily activities or he's more bed bound. So, all of these functional and general properties are also important when you are assessing this patient preoperatively. The other important factor is neuromuscular weakness, and understandably so, because that will again result in poor reflexes, poor cough reflex, poor strength, and decreased use of respiratory muscles, also, which will result in more complications. Obesity and obstructive sleep apnea are two very important factors, and in fact, as a pulmonologist, if we look at any patient preoperatively and he is having obesity or a chance of obstructive sleep apnea, that will increase the perioperative risk. It also will increase the risk of reintubation after a GA, and there will be a more risk of ICU transfers. So, ideally, if a patient having obesity or OSA is undergoing a major surgery, this risk has to be taken care of. The patient should be initiated on CPAP prior to the surgery itself to optimize him. COPD is an independent risk factor which just doubles the risk of postoperative complications, and with emphysema, the risk is even more. Also, other conditions like the interstitial lung disease and other conditions of the respiratory compliance, respiratory muscles, pulmonary congestion like pulmonary edema, gas exchange abnormalities, or where there is upper airway resistance will also increase the risk of post-op complications. And perioperative anemia, even mild, has been seen as an independent factor to increase the risk of pulmonary complications after a surgery. So, these are the patient related factors that one must see in a pre op evaluation or clearance. But what are the surgery related factors? So, one must be aware of the type of surgery that is being planned. And ideally, the dictum is that the more proximal the site of the surgeries to the lungs, there is more risk of post-op pulmonary complications. So, an upper abdominal surgery, a gallbladder surgery, or a surgery involving the breast, the upper spine. So, any surgery which is proximal to the lungs will have more complication versus a surgery of the periphery, say an orthopedic surgery, which is involving the foot and the ankle, for example. And as I said, the surgical urgency is very, very important. And in fact, data suggests that a planned surgery will have lesser risk, and an emergency surgery will have more risk for several reasons. Again, we must know whether the duration of the surgery or anesthesia is going to be a long one or it's going to be a short surgery. If there is a chance that this patient is undergoing a CABG or is undergoing any surgery which will last more than 4 hours, the chance or the risk of PPC will increase. Also, because pulmonary edema is a very common complication post-op, especially in cardiac surgeries, a volume administration administered during surgery is a very important factor that will determine our post-op complications. There are also complications related to the anesthesia that your patient will be having. So, we all know that general anesthesia, neuromuscular blockade, they are all related to more higher chances of dependence on the ventilator or respiratory failure. So, a neuraxial blockade, a regional anesthesia will always be preferable. So, for example, a patient is undergoing a knee surgery, then we must mention that it is preferable that this patient undergoes the knee surgery in a regional anesthesia or a spinal anesthesia if possible, rather than undergoing a general anesthesia, and that will directly decrease the chances of post-op complications. And use of neuromuscular blockade definitely increases the risk of post-op pneumonia as well as respiratory failure. Post procedure also, if we talk about thoracic surgeries like post thoracotomy, then there is a decrease in respiratory function that can even last weeks. In fact, patients, even without a pulmonary disease, can have a decrease in vital capacity of up to 60 to 70% immediately post thoracotomy. And the recovery back to their normal status and baseline may take 1 to 2 weeks. So it's very important for patients to understand this preoperatively and for us also to prepare them well in advance. If a patient is suffering from COPD or asthma or an ILD or any other pulmonary disease, then there are even more chances of this decrease in respiratory function. And mostly the reason is atelectasis, mucus retention, and worsening of their gas exchange. So, what should be an approach ideally now having understood that there are various factors which are involved in patients' post operative pulmonary complications? So, it starts with a very good history to understand the risk factors and a good examination and investigation. So, we have to ensure that the overall cardiopulmonary fitness of this patient is good. The patient has stable vitals or patient is on medications to ensure that he is fit cardiopulmonary before the surgery. Also, if he has an underlying lung disease, it has to be well managed. So that history is really important. A patient who's already in congestive cardiac failure will perform poorly post-op if not optimized. So that is very important. As I said, smoking history, because this is something we can modify, functional status, and definitely an active respiratory infection or a recent respiratory symptom is also something that one should be noting of. So once you've checked the vitals, the oxygen saturation at rest, you can also look at the Malampati class. This is more for an anesthetist point of view, but it would be good to notice that for terms of difficult intubation. A cuff test is a simple test that can also be performed. It's not a very accurate test, but here when the patient attempts deep breathing and then coughs involuntarily, if the cough starts happening on deep breath, then it is said to be a predictor of post-op pulmonary complications. It's a crude test that can be done at the bedside. A stop bank questionnaire becomes important, or any other form of screening tool for OSA becomes important when we are looking at obese patients who are undergoing surgery. This is a summary of the perioperative risk assessment tools, and this basically tells us that there are many risk quantification tools which are available, which can be used preoperatively. Anesthetists use a lot of them, but the only problem here is that there are so many that there is no specific tool that one can really recommend. And they all have come out of various trials and studies, so they cater to specific populations, and whether they will be able to be used as it is in another population is something which is difficult to say. Also, the definition of the complications are different. Each model evaluates different outcomes. There's a lot of variability inter-observer. So what one can say is that you could use these tools along with your clinical judgment, along with the various tests that one has to do, because a risk category relative to that particular patient population is something that one is looking at. So, a good clinical assessment, patient preferences, risk stratification tools, an anesthetist or surgeon's assessment of this patient, that gives us a more holistic approach. However, there are these tools. One of those tools which frequently anesthetists use is ARISCAT index, which utilizes the preoperative SpO2, respiratory infection in last month, pre-op anemia, surgical incision site, duration of the surgery, and whether it's an emergency procedure to determine what is the risk. There's also certain indices like the revised Goldman criteria, which one may use because it combines cardiopulmonary risk factors, so both cardiac and pulmonary specific, like obesity, smoking, cough, diffuse wheezing, preoperatively, a reduced pyrometric volume and ratio, and hypercapnia, which is more tuned to cardiac and pulmonary risk factors. Anyways, the American Society of Anesthesiology has an ASA class, which is also something which anesthesiologists look into very closely, with ASA 1 being a normal healthy patient and ASA 6 being someone who's brain dead. So between these, what is the functional status of the patient, whether his disease is controlled is defined, and that again determines the pulmonary risk factors. It's important when we are assessing, examining to now act and reduce these pre-op factors. So, as I said, encouraging smoking cessation in all elective surgeries, treating their asthma and COPD with bronchodilators, with inhaled steroids as and when needed, giving antibiotics if there's a current infection, and probably delaying the surgery if possible, and also telling the patient that post-operatively he has to perform an incentive spirometry, lung expansion maneuvers, a rehab or a chest physiotherapy, and that has to be, that directive or advice has to be given very clearly to the patient as well as to the treating surgeon. Intraoperatively, we can try to limit the surgery duration to less than 4 hours. We can use regional anesthesia like spinal epidural. We can avoid neuromuscular blockades, and we can prefer laparoscopic surgeries instead of open abdominal surgeries, which will make a difference in the post-op period. Also, post-operatively, whenever you are giving a clearance for a patient who already has a pre-existing lung disease, you have to inform them to perform deep breathing exercises or incentive spiro post-op. Keep the patient as propped up if possible, if the surgery permits. Um, uh, a 35 or 45 degrees lying down position would be better if it is permissible from the surgery. For example, if it's a knee surgery or an ankle surgery, using epidural or other regional anesthesias, and postoperatively for analgesia, it's very important that that is done, because again that reduces the vital capacity. They are recommended, there's variable efficacy, but these are some things that one has to instill upon. If we talk about the testing, then we know that spirometry is a very important part, and specifically for patients who have an underlying lung disease, say a COPD or an asthmatic or a heavy smoker, spirometry must be done before the surgery. So, because the forced expiratory volume in first, second, and as well as the FVC are very good indirect measures of the pulmonary reserves, and that can tell us whether this patient needs to be optimized pre and post operatively. Blood gas analysis, again, when there is hypoxia or suspicion of hypercapnia, is important, and a good assessment of especially airflow obstruction is really important while evaluating these patients. These are the criteria for estimating the post-op risk in lung resective surgery. So if we're talking about a lobectomy or a pneumonectomy or any resection surgeries involving the lung, then we prefer that the FEV1 should not be less than 50% of predicted if possible, that because that will increase the risk. So if the FEV1 is less than 50% or less than 2 liters, the risk is increased. If the FEV1 is less than 1 liter, then the risk is very high. The DLCO is also another factor, which is a very good estimate. So again, DLCO less than 60% will be an increased risk. And on blood gas analysis, a hypercapnia more than 45 or a hypoxia with a saturation less than 90 pre-op will be increasing the risk. When we talk about extrathoracic surgeries or where resection is not involved, there also the FEV1 is an important criteria, but this can be taken as a liter here instead, and 60% can be taken as a cutoff of the predicted value. Also, we don't want our patient to be hypoxic because it will increase the risk, and hypercapnia will also increase the risk. So if there is a patient which we now know is at risk based on his history, based on examination, based on his underlying lung disease, then we have to undergo a detailed lung function study. There's also split lung function studies, which I'll be telling briefly, which are done in resective surgeries, along with either a quantitative lung scan, say a VQ scan, or a dynamic contrast inhalants perfusion scan, especially in resective surgeries, lung resection surgeries, thoracic surgeries, or a CT scan before the surgery. And if there is a borderline estimated value, if then patients must undergo cardiopulmonary exercise testing as well. Talking about DLCO, as I defined, DLCO less than 60% is a cutoff for major pulmonary resection because it's an independent predictor of mortality and morbidity after the resection. So, for patients, especially whose spirometric values are less than 2 liters, one may go ahead and do a DLCO. And just like split lung function studies, a post operative DLCO value can also be calculated, and if it's less than 40%, there is a higher risk. Cardiopulmonary exercise testing comes to the rescue when these things are borderline. We have to take the patient for lung resection if it's possible. It's not easily available everywhere, but when available, when in doubt, then these can be taken. So it's a comprehensive investigation because it assesses cardiopulmonary reserve, and patient can uh, be tested on an incremental exercise, on a treadmill or a bicycle ergometer. And the main value that we're looking here for pre-op clearance is the VO2 max. So the level of work achieved, which is the maximum oxygen consumption, VO2 max is a very important criteria. And if the patient's preoperative VO2 max is more than 20 milliliters per kg per minute, there is no increased risk of surgery or complication death. If there is a VO2 max which is less than 10, there's a very high risk, and the cutoff here can be taken as 15, which will show an increased risk. So if the VO2 max is less than 15 ml per kg per minute, there's increased mortality other than non-surgical procedures also. And so this is, especially in lung cancer surgery, has to be taken as a cutoff. So, a patient who has to undergo a lung resection surgery, particularly, or a thoracic surgery, the pulmonary function testing, we prefer FEV1 to be above 2 liters or 60% of predicted, and a DLCO above 60%, and then you can take him for the surgery. If not, then we look at split lung functions, which look at the lung function after the resection, and these should be above 40% for both FEV1 and DLCO, and then you can take him for the surgery. If things are not clear and borderline, we prefer to do a cardiopulmonary exercise test. A VO2 max above 15 should send the patient for surgery. Otherwise, we look at other procedures if possible. This is another test that can be used instead of exhaustive cardiopulmonary exercise test if that's not available. This is the stair climbing test. There are no clear-cut cutoffs, but it is estimated that in stair climbing, a speed of ascent of 15 per minute 15 meters a minute is almost equivalent to a good VO2 max. So, if the patient has such a speed of stair climbing, we can say that he will be having a good cardiopulmonary reserve, but a speed of 12 is almost equivalent to a cutoff of 15. There are certain other simple non-invasive tests. There are no cutoffs but can be done bedside, such as a single breath count, a breath hold, and a 6-minute walk test or a shuttle test. And in a shuttle test, a good distance, best distance of less than 250 meters, or a desaturation during the test of more than 4% SpO2 will be categorized as a high risk for surgery. So, what is the split lung function test? Now, we know that the lung function may not predict the entire lung status because there may be some part of the lung which is non contributory. For example, with a tumor, with a mouse. So, what we do is we remove that contributed part and non contributing part, and then we look at the pulmonary function to see what the lung function will be post operatively. So, this is called a split lung function test estimation. The best method of doing that uses a quantitative ventilation perfusion scan at present, and it is said that these perfusion scans will correlate better than the pulmonary function. So we calculate the FEV1 volume of the left of a lung by knowing the percentage of perfusion to the left and the right lung. So for example, if a patient's preoperative FEV1 is 1.5 liters, The right lung is getting a 30% perfusion, the left lung is getting a 70% perfusion. The tumor is in the right lung. So then after resection, we expect that 70% of 1.5 will be what will be left. So that is 800, and a minimum FEV1 of 800, say in a COPD, will be acceptable. So then this patient can undergo this procedure, this resection. And if the predicted postoperative FEV1 is less than 800, he's not a candidate for pneumonectomy. We may have to look for more procedures with spare, so such as a lobectomy. So in summary, we have to ensure that the patient has a good cardiopulmonary reserve. So the resting ECG, the resting saturation, vitals are the first thing. Secondly, if he has any ventilatory impairment, we must optimize it. So if it's an asthmatic, it's a COPD, we make sure that we optimize them. We perform a spirometry. If needed, also perform a DLCO. If these tests are borderline non-contributory, a cardiopulmonary exercise test or other tests can be performed. And if there is a pulmonary resection, split lung functions can be assessed. This is a flowchart from the ERS ESTS clinical guidelines for lung cancer patients' fitness for surgery. But what you see here is a cardiac assessment followed by FEV1 and DLCO, both good, resection up to pneumonectomy. If either one is less than 80, exercise testing here. So here the cutoff is being taken as 80 for radical lung resection. And then split lung functions. The cutoff here is 30% according to these guidelines, and resection up to the calculated extent, or a lobectomy or pneumonectomy based on the values. So that's all today in preoperative pulmonary fitness. When we talk about lung cancer surgeries or resection surgeries, even more complicated conundrum of evaluation, formulas, and split lung function can be done. But in general, it's really important to look at the complications that may arise post-op right at the time of clearance and address them with clear-cut indications of what needs to be done in the immediate post-op period. Thank you very much for listening, for subscribing and tuning. Keep subscribing and liking this channel. Thank you.